Good morning. Good morning, everyone. I want to begin with a land acknowledgement, acknowledging that Ottawa is built on unceded Algonquin and Anishinaabe territory. The peoples of Algonquin and Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. And now I'm thrilled to introduce our speaker for this morning, my good friend and colleague, Dr. Amy Plint. Dr. Plint is a pediatric emergency physician at CHEO, a professor of pediatrics and emergency medicine, a senior scientist at the CHEO Research Institute, and holds the Tier 1 University of Ottawa Research Chair in Pediatric Emergency Medicine. Her research focuses primarily on the emergency department management of respiratory illnesses and musculoskeletal injuries, and on improving patient safety in the emergency department. She has also mentored numerous trainees on projects in other areas in addition to these. She is currently leading a CIHR-funded international randomized trial of interventions for the treatment of bronchiolitis. Amy has also served as the chair and past chair of Pediatric Emergency Research Canada, a multi-center national network of health researchers. She has also served as a member of the board of directors for the Knowledge Mobilization Network, TREC, Translating Emergency Knowledge for Kids. She currently serves as an executive member for the International Research Collaboration Pediatric Emergency Research Network, also known as PERN. And in recognition of her outstanding mentorship and leadership in pediatric emergency research, the PERC network has recently created a new award in her honor, namely the Amy Plint Mentorship Award, which truly needs no further explanation. The title for her presentation this morning is Bronchiolitis, Managing the Wheezing Infant, and she's going to let us know that our job with bronchiolitis is not yet finished. So over to you, Dr. Plint.
Thank you, Mona. It's a very nice introduction. I'm happy to be here today. And as Mona said, I'm going to speak about bronchiolitis. Before I start, I'll just mention that I have no conflicts of interest or financial disclosures, but this presentation does include the discussion of off-label use of medications. I have three main objectives today. The first is to talk about bronchiolitis in the COVID era, to review evidence-based strategies in managing bronchiolitis in the ED, and to describe controversies in the management and some ongoing research that I'm involved in. Now, you might say, why now? Why are we talking about bronchiolitis? You look outside, you see the tulips are in bloom, and you think, wait a minute, why is Amy talking about bronchiolitis right now? Isn't it a wintertime disease? And of course, you'd be right, because usually bronchiolitis is a disease we see in the winter in Canada. And in fact, for most of my 25 odd years in the pediatric emergency department, the triage lineup at winters looks something like this. And in large part, that's due to being inundated with infants with bronchiolitis, which is an acute viral illness of the lower respiratory tract, typically caused by respiratory syncytial virus or RSV every year. In the US, there are at least 2 million ED visits annually for bronchiolitis and 8.75 million outpatient ED visits. Fortunately, we don't have similar cross-Canada data, but you can imagine proportionally, there is a lot. So it's really important to recognize that bronchiolitis remains the leading cause of infant hospitalizations, with 3.4 million admissions worldwide every year and over 200,000 deaths of children from it every year. In Canada, it is the leading cause of hospitalizations for infants less than a year of age, with on average about 35 per 1,000 children less than a year of age admitted each year. But it's important to recognize that the burden is significantly higher among different populations in Canada, and particularly our Indigenous people. One study from Quebec has shown that Indigenous children are twice as likely to be admitted to hospital with bronchiolitis, at about 65 per 1,000 children less than a year of age, compared to 28 per 1,000 among non-Indigenous children. And we see similar data like this from New Zealand and Australia, with the burden of illness, acute illness, being greater among Indigenous children. And as Tom Kovesi can tell you, the complications of bronchiolitis are also much higher among Indigenous children. But, you know, since the pandemic hit, visits to the ED have dropped worldwide, particularly for infectious illnesses such as bronchiolitis. I was thinking about having like a picture of the RSV virus and the coronavirus duking it out here, with the coronavirus definitely winning. And to put it in context, from October onwards, we have had 2 children admitted to CHIO who have tested positive for RSV, which is the most common cause of bronchiolitis. It has essentially disappeared this year in North America. Oops, sorry. But what does that mean? Well, the vast majority of children have an RSV infection before they're 2 years of age. But with the non-pharmacological interventions for COVID of masking, distancing, and intermittent school closures and daycare closures, we have at this point a large cohort of children that have never been exposed to RSV. And modeling has tried to look at what does this mean? And depending on the interaction of bronchiolitis seasonality, in winter, in North America, bronchiolitis is a winter disease. In places such as Florida, it's an all-year disease. In places such as New Zealand and Australia, it has a longer season overall. But when you model the seasonality and then the lengths of the non-pharmacological interventions for COVID, we get several different options. One is that we're going to have the worst bronchiolitis season probably of our lives in 2021 to 22. And not just bronchiolitis, but other RSV illnesses in children that are older than 1 that have never been exposed. We could also perhaps have a prolonged but less intense outbreak in 2020, 21, 22. Or finally, we can end up with what has been seen in Australia, which is a completely out of season bronchiolitis season that is above even their typical numbers. And so I pulled this slide to show you in Western Australia. So in Western Australia, you can see they've got the typical RSV season here, with it peaking in their winter or summertime. And here you can see, March when the borders closed, the various interventions that they had, slowly loosening of restrictions, school returning, and then boom, this is their summer. And the bronchiolitis season is above any peak that they've ever had, even in their worst time. And this has been also reinforced to me by physicians who sit on our international global network called PERN, in the form of sort of a Dear Doctor letter to the Northern Hemisphere, warning us what may be coming. So I think it's important to recognize that although this is May, and I'm talking about bronchiolitis, you may actually be really happy when August comes to have heard this talk. So I guess one of the other relevant questions in the COVID era is does SARS-CoV-2 actually cause bronchiolitis? So the answer is yes, it can, but it doesn't appear to be any significant cause of bronchiolitis at this point in the context of our non-pharmacological interventions. We know that coronaviruses in general can cause bronchiolitis, but they're quite low down on the list of viral causes. But there have been several reported cases of bronchiolitis where children have tested positive for SARS-CoV-2. But overall, as I mentioned, bronchiolitis is down at all EDs, including places that have had widespread COVID disease. So for example, in the States last spring, when COVID was, for example, very bad in the Philadelphia area, the children with appendicitis were more likely to have COVID than the kids with bronchiolitis. So I think it's important to recognize that although it can cause it at this point, it doesn't seem to be a huge cause of bronchiolitis. So now I'm just going to move on to talk a little bit more about the disease itself, treatments, and some studies. And I thought I would actually start off with one of my favorite all-time peer-reviewed quotes. So many years ago, I must have submitted a grant about 3 times, I'm going to present it today, to get funding for it. Now, one of the reviewers had multiple things they didn't like, but this was my favorite, that finally the symptoms of bronchiolitis last anywhere from 5 to 10 days. You can imagine that's not actually accurate. Bronchiolitis is not a 5 to 10 day illness. It presents with a constellation of clinical signs and symptoms, including coryza, cough, wheezing, crackles, and increased respiratory effort. The disease severity does typically peak around day 5, and there's this classic minute-to-minute variation in the children's symptoms secondary to the underlying pathology of disease. And anybody who's managed these children clinically have seen this. But it's important to recognize that the overall median duration of cough in research that I've done has been shown to be at least 12 days, with a significant number of children continuing to have symptoms, almost 20% at 21 days and almost 10% at 28 days. So it's definitely not a 5-day illness. Now, what is the pathophysiology of bronchiolitis? When people ask me what I study, I talk about it with lay people. I say it's kind of like asthma in babies, but that's really probably not a good description because the pathophysiology is different than asthma, although there are similarities in presentation. In the first few days of illness, the virus infects the upper respiratory tract epithelial cells. These cells are sloughed down to the lower respiratory tract. You end up with a plugging of the lower respiratory tract. The virus then affects the lower respiratory tract by sloughing the cells there. You have mucus production, edema, airway obstruction, and air trapping. Ancillary function is impaired. Usually, though, by about day 16 to 22, all of this has resolved with regeneration of the epithelium in the upper and lower respiratory tract infections. So I only talk about this because, many people treat bronchiolitis with similar medications to asthma, but it's important to recognize that the pathophysiology of RSV infection in a young infant is some degree different than asthma. Not saying you don't have edema and mucus production, but this sloughing of the cells into the respiratory tract is an important feature. So moving on now, we've sort of talked about the burden of disease and the pathophysiology. The question is, how do we diagnose bronchiolitis? Do we need any tests to make sure that this is bronchiolitis? And, the bottom line answer to that is no. Bronchiolitis is a clinical diagnosis. It's made on the basis of typical history and physical exam. It's typically described as a first, although not always, this could be second, episode of wheezing in the young child, typically less than a year of age, some would say less than 2 years of age, in the typical RSV season. The vast majority of studies, when they enroll kids with a clinical diagnosis of bronchiolitis, the median age is 5 months of age. But it's a clinical diagnosis. And there's absolutely no need to do viral testing to diagnose bronchiolitis. The vast majority of children have RSV infection, up to 80% in most studies. And as I mentioned earlier, other viruses are associated with bronchiolitis, including rhinovirus, metapneumovirus, coronaviruses, influenza, adeno-parainfluenza, etc. And studies have investigated whether the severity of illness could be associated with a specific virus or co-infection. And that could be one reason why you might consider testing if you knew that a child was at higher risk for particular viruses. But the data for that is conflicting. In studies where patients are infected with just a single virus, RSV does seem to be associated with a more severe course compared to other viruses. But up to 30% of children with RSV are shown to have co-infection, so infected with at least one other virus. And there is some evidence that suggests co-infections, particularly RSV with rhinovirus or metapneumovirus, could be associated with more severe disease than infection by a single virus. But again, the evidence is mixed on that situation. And from a clinical point of view, treating the children in the emergency department and on the wards or in your office, there's no clinical benefit to understanding what virus is causing it at this point. Certainly in our hospital, we tested for cohorting, and I imagine in the COVID era that will continue, although it's not, every hospital has not previously tested for viruses for cohorting. But again, that was pre-COVID. So what about x-rays? Certainly when I was a resident 25 years ago, it seemed like every patient had an x-ray with bronchiolitis. But in fact, x-rays are seldom useful. There's been a very elegant study by Suzanne Shu, who's an emergency physician at the Hospital for Sick Children. And in this study, she took 265 children with typical bronchiolitis season. And of those 265, only 2 children had x-rays that ended up giving them a different diagnosis. You would have needed, in other words, 133 x-rays to identify one alternative diagnosis. The important thing, though, is increase the use of antibiotics by 5 times. They asked people before the x-ray were done, were you going to give antibiotics? And then asked them afterwards. And they saw 5 times increase. So I think it's really important to recognize that the vast majority of children with bronchiolitis, chest x-rays are not needed. Now, interestingly, across Canada, certainly in the pediatric emergency departments, x-ray use is not incredibly common, but it's still common enough that in 2016, it was at about 34%. So certainly, I think we have some room to go from here. Data from the US and another study I've been involved in has suggested that among non-pediatric centers, it ranges up to even 75% of children, even in the last few years, getting x-rays with bronchiolitis. So I think we still have work to do in this setting. Now, what about other tests? Do we need to worry about doing, quote, full septic workups on young babies that come in with bronchiolitis? So we know that children with RSV bronchiolitis have have a low risk of bacteremia. In the pneumococcal era, it's less than 1%, 0.1% risk. If you look exclusively at febrile infants less than 60 days of age with clinical bronchiolitis, their UTI risk is about 5%. And that is about half the risk of infants without bronchiolitis. So the data would suggest that definitely for febrile infants less than 60 days of age with bronchiolitis, it's at least we should continue to do a urinary catheterization to look for risk of urinary tract infections. So we talked a little bit about what tests to do, how to diagnose it. And I guess the other question is, who do I worry about? I always say to the residents, one of the worst situations is when you sent a kid home, on your shift, and then you come back the next day and they're in the resuscitation room. I don't think it's something any of us enjoy seeing happen. Now, luckily though, in bronchiolitis, severe outcomes are really quite uncommon. In a Canadian-wide study that I did, we found in Canada it was about a 2% risk of ICU admission overall. In a global study that we undertook as part of Pediatric Emergency Research Network that enrolled almost 3,000 patients, 2% of them needed non-invasive ventilation or intubation, although almost 10% required what they considered escalated care. So escalated care included obviously non-invasive ventilation and intubation, but it also included just ICU admission with or without ventilation and high flow the use of high flow nasal cannula. So although the vast majority of kids do well, there is still some risk of severe disease. So using that data, we tried to develop whether there was any scoring system that you could use to determine who would be at risk of bronchiolitis. So in that study, we were able to create a score that showed the increased risk of escalated care. So we had age, these are all clinical things I think most people would think about: age less than or equal 2 months of age, poor feeding, oxygen saturations less than 90%, apnea, nasal flaring or grunting, dehydration, and retractions. And using this model, because people get all different scores, the area under the curve was actually quite good at 85%. Now, I should mention that this model has not yet been prospectively validated. Hopefully that will be a next step. But to put in context how this kind of modeling could be useful, if you imagine you have a 1-month-old infant with poor feeding who's dehydrated with a SAT less than 90%, they would get 8 points. Now, clearly this child needs to be admitted, but with the scoring system would suggest they have a 50% chance of escalated care. And I think that this data can be very helpful for people working in community hospitals, trying to decide who they may need to transfer to a tertiary care center, particularly in places where access to tertiary care is more remote. So again, this model does need to be validated, but I mention it as data we have out there that is, I think, useful and hopefully will be validated, and I think fits clinically with what many of us consider, right? The young infants are at higher risk. Obviously, a child with apnea is at higher risk, but I think it could be helpful in the future in community settings. So what about treatment? Um, we we know who may get sick, but have we got anything that we can offer to these children? Well, I think we need to just say like our treatment is not great at all. Um, Bronchiolitis is a self-limited viral illness. The vast majority of children do well, and you really want to make sure we do no harm. So what do we do know? Well, we do know that supportive care is important and that this is endorsed by all published guidelines. So when we're talking supportive care, what do we mean? The North American guidelines all suggest admission to hospital if oxygen saturations are less than 90%. Um, although the New Zealand and Australia called PREDICT guidelines recommend less than 92%. It's really important to consider the appropriate use of pulse oximetry, as arbitrary thresholds definitely drive admissions and length of stay. And I know that I believe that Catherine Pound is involved in a study here at CHIO, even looking at continuous versus intermittent oxygen saturations that'll look at this very question. Again, though, to talk about a study that Suzanne Shu led at Sick Kids, I'd just like to show this data here. In this study, she had about 200 children, and she artificially increased their oxygen saturations by about 3%, and then looked at who was admitted within that 72 hours of that ED visit. And interestingly, among the children that she artificially increased the saturations, only 25% were admitted versus 41% in the true saturation group. Now, it's important to recognize that this study is a bit old, that the vast majority of children already had SATs over 90%, but still, I think this sort of just shows how much oxygen saturations can drive admissions. Interestingly, in the UK, the guideline for admission had previously been 94% oxygen saturations. Once they dropped it to 90%, they found that children were discharged earlier and they had no increased risk of adverse outcomes that were reported. So again, consider oxygen saturation in the context of the overall picture of the child. And I think this is one of the most fascinating studies I think that I've seen in bronchiolitis. And it just points out how common intermittent hypoxia is in discharged infants. In this study, about 250 children were sent home with oxygen monitors from the emergency department. And among those, 64% had recurrent oxygen saturations of less than 90%, lasting 1 minute or longer. And among, it was 118, 75 had saturations less than 90%. And among those infants with these saturations, about 80% spent more than a minute at SATs less than 80%. 40% spent saturations at less than 70 for 1 minute. And overall, the mean length of desaturations was over 3 minutes. So, we sent home these kids with normal oxygen saturations, but many of them at home are having significant desaturations. So I think this is something I'm not quite sure what to do with this data at this point, but I think it reflects that, the use of continuous oximetry could definitely drive ongoing admission in hospital. Now, what about high flow nasal cannula and the use of that oxygen? So high flow nasal cannula, I think probably everybody's aware, is this form of respiratory support in which high flow rates of humidified heated gas are delivered into the nasal passages. And these rates are of higher flow than is traditionally delivered by the normal oxygen therapy. It can be delivered at a rate of up to 2 to 3 liters per kilo per minute, while usual oxygen saturation is 2 to 3 liters per minute, not per kilo. Mechanisms of action are uncertain, but they're thought probably to involve washout of nasopharyngeal dead space, reduced upper airway resistance, and a provision of a degree of positive pressure. So now, as bronchiolitis is a disease of the small airways, one could imagine that high flow nasal cannula can be a very attractive modality. So this study that I have on this slide here is the largest study of high flow oxygen in bronchiolitis. It involved almost 1,500 patients enrolled in Australia and New Zealand through the Predict network. This study, the primary outcome was what they considered escalation of care. And escalation of care was for clinical indications of increasing or no change in heart rate, respiratory rate, increasing oxygen needs, or triggering of the early hospital warning system. What they found is that children on high flow definitely had less risk of escalating care. But overall, among the two groups, there was no risk in the difference of ICU admission or length of stay. So the main conclusions from this study wasn't that everybody should go on high flow nasal cannula, but rather that it was safe to use on the ward. Should not be a reason per se to necessarily transfer patients from community hospitals to a pediatric center if they're comfortable with it, but that really it's a rescue therapy, that we use it when children are not managing well on regular oxygen. It's a next step. And I would say that that reflects how we use it at our institution as well. And the bottom line is over 2/3 of the patients do fine on regular oxygen. Now, what about IV versus NG? You know, many of these children do require fluids for hydration, and most guidelines recommend either nasogastric or intravenous fluids to maintain hydration. The UK and Scottish guidelines definitely prefer nasogastric or orogastric hydration. I can say that, you know, I don't know if there's been a switch on the boards here, but typically I have seen overall, we still tend to use IVs in the emergency department for this, although I do think there's a slow change switching over. And again, the Predict network undertook a study of about 750 infants of 12 children admitted to hospital with bronchiolitis, and they compared IV to NG and found no benefit of intravenous fluids over nasogastric in terms of length of stay, admission to the ICU, or need for ventilator support or adverse outcomes. And they did find that an NG tube was easier to place than an intravenous line in these children. So I think that, you know, it really sort of behooves us to consider whether or not the sort of reliance on IV is the appropriate path. And then, you know, finally, moving on to the final supportive care we talk about is superficial suctioning. Because infants are obligate nasal breathers, nasal suctioning has been suggested to help with clearing of the nares, improve the work of breathing. However, suction can also irritate the nasal mucosa and result in edema. And the current published guidelines give different recommendations with regarding suctioning, but all those that do suggest only superficial versus deep suctioning. And really there's 2 studies in bronchiolitis that have looked at the benefits of suctioning. I mean, I think clinically we think it helps, but interestingly, when you look at these studies, one of which is a small observational study and another is a retrospective cohort, one of them suggests that deep suctioning could actually increase the length of stay for inpatients, but that infrequent suctioning is associated with an increased length of stay, and oxygen saturation might increase after suctioning. So while it might make you stay longer, but you might at the same time have a bit of improvement in oxygen saturation. So 2 pretty conflicting results there. I can tell you that we're undertaking a study, our PERC network right now, and CHIO is a site of it, that we've called SNOT, which we think is a great name for a suctioning study. And in this study, we're going to look at discharged patients, and some are going home with, what we're going to call our placebo, a fairly ineffective suctioning device, and then another, a battery-operated device. And we're going to look at the results of return visits to healthcare for those families, as well as a measure of many other measures. So I think stay tuned for the results of the SNOT study. So what about medications? You know, I think that lots of studies have shown that we continue to use medications in this. It includes things such as salbutamol, epinephrine, steroids. In work that I've done in the community, I saw patients get inhaled budesonide, Atrovent, and these are all kids less than 1 year of age in the typical bronchiolitis season. We're not talking about the 18-month-old presenting in the middle of the summer. So we continue to see this widespread medication use. And I think it's because clinicians are, you know, looking for something to help in these kids and are, see the symptoms of the wheezing and the distress, which is so very similar to asthma. So before I go on to talk about what we do know about medications, I'm actually going to talk a little bit about something called a network meta-analysis, because I'm going to present the results of this, which was just recently published in Pediatrics. So a network meta-analysis is a specialized statistical method that simultaneously compares multiple treatments from head-to-head trials and also trials comparing different treatments against a common comparator. And I'll show you a little bit more of what I mean by that. So in a traditional meta-analysis, so the Cochrane reviews that one would look at, we usually just do studies that are direct evidence comparison. So we have treatment A compared to treatment B, and that's the only two comparisons that we do. In a network meta-analysis, we do a combination of things. So we'll have treatment A compared to treatment B compared to treatment C, and this will allow us through specialized statistical methods to actually compare treatment C to treatment A. So to try to develop a comparative effectiveness of treatments. So we undertook network meta-analysis of multiple treatments in bronchiolitis. And we had three main outcomes that we were interested in. One was admission to hospital at day 1, so meaning at the time of presentation to the emergency department, admission to hospital by day 7, so including everybody admitted at day 1, but all the way up to day 7, because we know that about 30% of children are actually admitted on a second visit, at least in Canada. And then finally, we looked at hospital length of stay. We looked at children less than 2 years of age. In the studies, all the kids had to be less than 2 years of age and have a clinical diagnosis of bronchiolitis. So this is just an example of what the comparisons look like. And so you see we have these nodes here. The nodes represent the treatment examined. So here we have epinephrine, here we have salbutamol compared, and the size of the nodes represent the number of patients in each treatment. And the line widths are proportional to the number of direct comparisons. So you can see there was a lot of comparisons of salbutamol to epinephrine, but not so many of epinephrine and steroids to placebo, nebulized placebo. And then here we have even just basically air, so no placebo. So the most common comparisons, as I mentioned, is epi to salbutamol and epi to placebo. So when we look at this results for admission to hospital at day 1, this is what we find. So we determined that we would consider a clinically important threshold a 20% reduction in admission rates. And in the network meta-analysis, we found for day 1 that hypertonic saline plus salbutamol compared to placebo and epinephrine compared to placebo did reach this clinically important threshold of a 20% reduction in admission. But it's important to recognize that our confidence in these results is low to very low. And this is based on the quality of the studies, the heterogeneity of the studies. And so although we found these results, it's low to very low. So what about when we look at admission to hospital at day 7? And I consider this a more important measure than admission at day 1 because it really captures the more true course of patients with bronchiolitis, because we know that some present, day 1, day 2, but day 5 is when they're really bad and they end up needing to be admitted. So when we do that, we find in fact that there was no benefit to any treatments compared to placebo. But again, this result is considered low to very low confidence. What about on length of stay? So when we look at length of stay, we find that hypertonic saline plus epinephrine compared to placebo reduced the length of stay by about it's 0.9 days, where hypertonic saline alone reduced the length of stay by about 0.4 days. But again, the confidence in these results are low. And although this is a different statistical technique than is reported in Cochrane meta-analysis, when you do the Cochrane meta-analysis, these are basically the same results that you get, although there is some debate around the hypertonic saline results. So what does all this mean? Basically, what it means is we should all be following the national guidelines at this point, the international guidelines, which is bronchodilators are not routinely recommended, hypertonic saline is not routinely recommended, and steroids are not recommended. And I just want to mention here for a minute that a lot of clinicians say, well, you know, my baby has eczema that I'm treating, the parents have asthma, the siblings have asthma. I'm going to use steroids because I know that that helps in asthma, and maybe this child has asthma. That's actually been looked at in two large studies, one of which I led, and one from the States. And when you look at the subgroup of children that have either a personal history of ATP in the form of eczema or a family history of asthma, they do not respond any differently to steroids than those children that don't. So although we think that clinically in the typical 5-month-old showing up in RSV season who has eczema, steroids still seem to have no benefit. But one of the issues with meta-analysis is that, you know, whatever you do is limited by the quality of the studies. And there is evidence to suggest that data from a single large methodologically sound study is better than meta-analysis. And so that leads me to talk, of course, about a study that I completed 10 years ago, in which all guidelines recommend further study. And in this study, we looked at the benefits of epinephrine and dexamethasone in children with bronchiolitis. I'll just give a little shout out here to Rhonda Carell, who you guys all know is our operations director now. So she was the coordinator for this study, and it never have happened without her. So I'm just going to put that out there again today. So in this study, we compared epinephrine to placebo, dexamethasone to placebo, and epinephrine and dexamethasone to placebo. And why did we do this study? Well, we had some evidence that beta agonists and steroids could work synergistically in asthma, but was this the case in bronchiolitis? And this is the main result from the study. It was 800 patients, an 8-center study. And here you can see this is your combined group of epinephrine and dexamethasone. This is our epinephrine group, dexamethasone, and placebo. And our primary outcome was admission to day 7. You can see that, you know, these lines are definitely separated. There was about a 9% reduction in admissions, absolute compared to placebo with epinephrine and dexamethasone, and a relative risk reduction of about 35%. Now, you know, when I did this study, I was like, woohoo, awesome. You know, bronchiolitis costs $500 million a year in the United States. I've just saved us lots of money in the healthcare system. But these results caused significant controversy, and they've not gone into widespread practice. And all guidelines are calling for future studies in this area. And I'm going to talk a little bit about, you know, why I think the study didn't translate and what we're doing going forward to really try to answer this question. So I think one of the first things is how we define bronchiolitis in a clinical trial versus how clinicians define bronchiolitis. There's a study led by the head of the Child Cochrane Health Field where he surveyed pediatricians and GPs in Europe. I most agreed that bronchiolitis is a seasonal illness characterized by typical fever, cough, etc. Only 30% felt it was the first episode of wheezing, and only 14% diagnosed bronchiolitis only in children up to 12 months of age. But typically in North American studies, we consider it the first episode of wheezing in kids less than 12 months of age. So I think there's a debate around, you know, what is bronchiolitis? I think one thing that is very clear is the whopping dose of steroids we used in this study. We used a huge dose. I would never do it again. We used 1 mg per kilo in the ED and 0.6 mg per kilo for 5 days. We based this study on the only dose that had shown any benefit in bronchiolitis. It was a small study that had been done a few years earlier. And in fact, I had initially a smaller dose in my grant proposal, but the CIHR RCT panel requested that we use this dose. People are concerned not only of adrenal suppression with this dose, but also there's concern about neurodevelopmental risk in children using such a high dose. Really, the risk appears to be in very low birth weight infants given steroids, you know, in the first few days of life, rather than likely in term infants. But whether or not it's a real risk, clinicians are just not happy with this dose. And I think one of the issues is we need to keep these things simple. This was a complicated trial design. I did something called a factorial design, which assumes it's a 2-in-1 trial. So there are 800 patients, 400 got, but we were assuming we could just compare the patients that got dexamethasone to those that got placebo, and the patients that got epinephrine to those that got placebo. we're hoping to compare 400 to 400. But then when you see those results, you can see there's clearly an interaction between epinephrine and dexamethasone. So then there became this whole debate about how to analyze this trial. And so this is another way of showing the results. And here you can see the relative risk in epinephrine and dexamethasone at day 7 compared to placebo. But you see these little red bars is the adjusted risk. So there's a whole debate in this kind of trial design whether one would do a statistical adjustment, in which case you get this red number and you're just not significant, a P of like 0.07, or whether you wouldn't adjust and then you'd say it was a significant result. So, as that result of that is the translation became harder. And I'm not sure whether another journal would have insisted on that presentation of results and whether or not it may have actually changed how this study would have been done. Nevertheless, what does that lead us to? So what it leads it to is me doing, and then the final issue I think is publication restrictions. Synergy is real. There is a real synergy between beta agonists and steroids in terms of enhancement of gene expression related to anti-inflammatory processes. But, the journal was just like, blink and you can miss it. You're allowed to put like 2 lines in it. So I think that these things also don't help. So what are we doing instead? So our next steps is I'm doing another trial. We skipped a bunch here. We're undertaking another RCT comparing epinephrine and dexamethasone to placebo in the treatments of infant with bronchiolitis. It's a CIHR funded as well as funding from Australia and New Zealand. We are taking place at 12 hospitals, 6 in Canada, 3 in New Zealand, and 3 in Australia. It's a joint collaboration between Predict and PERC, our network in Canada. We're enrolling kids 6 weeks of age to less than 12 months of age with bronchiolitis. We have decided that it does not have to be the first episode, in that we are really trying to reflect true clinical practice. Interestingly, this is how they enroll children in bronchiolitis in New Zealand and Australia. Yet when you look at their baseline tables, the baseline tables are almost identical in terms of age of the patients. Our interventions are inhaled epinephrine or placebo for 2 treatments in the ED, and dexamethasone or placebo 0.6 milligrams per kilo just for 2 doses, rather than the 6 doses that we gave in CAN-BEST, our bronchiolitis trial, and admission to hospital by day 7. So we've done this change in dosing because you can see that most of the effect was in the first few days. And we felt that clinicians, we had good basic science for why this would be true, and we felt that clinicians would be comfortable with that dose of 0.6 per kilo because it's the dose we use in croup, and I just wasn't going to take 8 years to do another study that may not translate into practice if positive. So what else are we doing besides this RCT to try to help with the knowledge translation of any results? So as I mentioned, we're undertaking this pragmatic trial of epinephrine and dexamethasone. We're also doing a couple other things. We're undertaking a neurodevelopmental follow-up of children enrolled in CAN-BEST, which now is 10 to 12 years, more than that later. And this is a CIHR funded multi-center study. So we're hoping to be able to answer any questions about the risks of steroids on young infants. My postdoc, Khosari Abdullah, is also undertaking a study looking at the long-term effects of CAN-BEST treatment on respiratory health with support of our respirology colleagues here at CHIO. She's using ISIS data to look at the risk of asthma in the various CAN-BEST arms out into the future. We're also undertaking something called the discrete choice simulation. And what we're doing here is we're taking all the CAN-BEST data and plugging it into a simulated emergency department. So we have the arrival times of patients, the typical time till they're seen, the wait for a bed, patients, do they come back, depending which study arm they're in, and we're modeling the effects on the actual flow of the emergency department to see what this treatment options would have. And finally, we're undertaking a reanalysis of CAN-BEST. So years ago when we did CAN-BEST, we used something called a frequentist approach, which is I think what all of us are used to. You start off with the idea that, is this better or not? You have your traditional p-values, and then you take your results. But a Bayesian analysis considers pre-existing knowledge and what you need basically to be convinced as to whether or not this is an effective treatment. So we're undertaking that, and I can just give you a little sneak peek that in fact the Bayesian analysis would suggest that, even unless you're incredibly skeptical, that the CAN-BEST results should have changed your practice. So those are the main things we're undertaking to move forward. So where does that leave us, the bedside clinician managing bronchiolitis? I think bottom line is bronchiolitis is the clinical diagnosis. Investigations aren't needed. Supportive care, no bronchiolitis, no steroids. Stay tuned for about 5 years from now if we ever get bronchiolitis again. And I'll be talking about our results of epinephrine and dexamethasone combined therapy. And get prepared for finishing off the COVID pandemic by being inundated with infants and toddlers with RSV infection, either off season or in the winter of 21-22. And thank you. Any questions?
Okay, thank you, Amy. That was a fabulous presentation. Really brought us from the beginning to where we are now. Sometimes it feels like after all these years, we still don't know what to do with bronchiolitis, but I think you've really highlighted things that we should be doing, things that we should be doing. And it's great that there's all this fantastic international research that's really going to help answer the questions for us. So when it comes back, we're going to be more ready. We have some time for questions. So I think Alex has his hand up, his real hand up.
Hi, Amy. Quintessential Plintian clarity. Just a paragon of lucidity. What a great talk. Just brilliant. So you think high steroids might make the difference? If you stratified and looked back for studies that looked at used your dose of steroids in the past literature, do you see the needle moving a bit? And then a second question, post RSV vaccine, how does the world change?
Yeah, so two things. First of all, there's only 2 studies that used our dose.
Right.
There are several small studies, and I think it's important to recognize it's not just the steroids, it's the steroids with the beta agonist, and the timing appears to be crucial. There's like a whole basic science that I could have gone down the path of, but I thought people would be bored to death by that. Sorry, Alex.
A little offended.
No, I'm just kidding. But the important thing seems to be truly the timing of those 2 medications, that having them spread apart does not give the synergistic benefit. And I think, my respirology colleagues are way more experienced in this, but, I think it's the whole reason we have the combined, puffers for patients with long-acting beta agonists and steroids. And so, yes, there's other studies that suggest there's benefits. There's basic science evidence. And when we try to tease out in meta-analysis studies where they used beta agonists and steroids, it does look like the 2 together have a benefit. It might be one of the reasons why we have such diverse results. Like, many studies of steroids early on, everybody got salbutamol because that's what we did. But they didn't consider that in the analysis. But when you then consider that patients got salbutamol, which is a beta agonist, we don't know, maybe salbutamol would be just as good as epinephrine, but at this point our evidence is around epinephrine, so we're using that. I think that could explain some of the variation in results. Now your next question, RSV vaccine. Well, I guess I'll be out of a job, which would be just
okay.
But, it's been a long path to an RSV vaccine. At this point, we don't have one successful one. But, I do think we will see a change if we ever, get a good vaccine for it. Yeah.
Okay. All right. Great. Thanks.
Okay. Tom Kavesi has a question for us. Go ahead, Tom.
Let me get successfully unmuted here. Amy, thanks for a wonderful talk. A couple of quick thoughts. First, I think it's important to keep in mind that epinephrine is an alpha agonist and a beta agonist.
Yeah.
And that's really important because the alpha agonist is a topical vasoconstrictor effect that may be really important in bronchiolitis. There's a lovely study from Winnipeg where they looked at changes in airway resistance after epi or salbutamol for bronchiolitis, RSV bronchiolitis. And they found about 90% of babies had improvement in airway resistance after epi and 50% after salbutamol. So I think it's definitely the better drug to choose.
Yeah.
One place where I'll admit I disagree a little bit with the national guidelines is the use of bronchodilators for bronchiolitis. Because I think it depends on the outcomes you choose. Clearly, bronchodilators by themselves do not change the natural course of this disease. Totally agree. The question is, do some kids get symptomatic improvement? And to me, the analogy is we all use ibuprofen or acetaminophen for pneumonia. It doesn't change length of stay, it never will, but it makes some kids feel better. And so I think for selected kids, trying it, looking carefully at whether they look like they're more comfortable afterwards, and absolutely stopping it if it makes no difference, still may have a role.
Yeah, I think that that's a good point, Tom, and it's one that I struggle with. You know, if we look at the markers of sort of true improvement in terms of, you know, the kid looks well enough to go home, you know, for sure they don't seem at this point to have a role. You can say that, you know, in New Zealand and Australia, they just don't use them. And in fact, one of the challenges for enrolling patients in the study, although has been that parents don't want kids to have any treatment because the sort of culture is that they don't make any difference. I think some emerge docs would say, you know, we don't know what it is, but sometimes we give them the epi, we feel that they look better. You know, maybe they woke up better, woke up a bit, you know, got a bit stimulated, drank something and got better. But I think that, you know, we don't really have great answers. We don't have great tools. You know, we use the tool of admission for an outcome. We don't have a great tool for measuring the respiratory status of children. You know, we have the RDAI, which, you know, we've done work on and done some validation that it, you know, at least seems to semi-correlate with admission, but we don't have a great sort of symptom-based score for bronchiolitis and sort of something that's more almost patient-oriented. And I think that those are valid points, that they may not things may not necessarily change the overall course. But the other thing I would caution is that at this point, you know, epinephrine, although for my trial I didn't mention it, we're switching to MDIs for epi, is that, you know, we have to give bronchiolitis drugs with a nebulizer, right? And although in Ontario it's not considered an aerosolized generating medical procedure, in many other jurisdictions of the world it is. And I think that, you know, not to like go down the whole COVID N95 path, but I think that, you know, this is the data, right? The risk of SARS-CoV-1 transmission from a meta-analysis using nebulizers was 0.9, but the confidence intervals are huge. And having looked at about, you know, I'm sure you've looked at even more of this, but about 30 odd articles by this, I think these are still important questions that we really need to reflect on using treatments. Again, COVID doesn't seem to be a big cause of bronchiolitis, but, you know, there's certainly bedside anxiety right around this. So I guess my comment would be, I hear you. I do think there are nuances that aren't captured in the guidelines, and the verdict's still out.
And finally, just been a real quick plug, but totally agree with you that when a baby is critically ill on the ward, they should be in continuous oximetry monitoring. As soon as that child's getting better, waking up more, moving around more, absolutely the ward should be switching them to intermittent monitoring. Sat monitors lie, and the longer you leave them on a baby, the more time they're going to spend lying.
Okay, thank you, Tom. Next question to Jason Berman.
Can you hear me okay?
Yep, we can hear you.
Great. Thanks, Amy, for a terrific presentation. Really enjoyed it. And my question is more around process than outcomes. You've been extremely successful interacting with leading networks to be able to do multi-centered trial both across Canada and internationally, which for some of the junior faculty on the call and trainees may seem very overwhelming and intimidating. I wonder if you could speak a little bit around how one engages with networks and participates with networks to do this kind of these kinds of trials.
So I guess the first thing that helps obviously is to have a strong national network. And I was with PERC from the beginning, as the longest serving executive member ever. So I think that there was an advantage there, getting in at the ground floor. But I think one of the reasons I've been successful is mentorship. So within the network, we have so many amazing mentors, and having been mentored through the trial, to also being sure to engage with people, that it's not all about the glory just to you or your university. It's the greater issue is the question, right? And that participating that you have a team of people who feel that, right? That, you know, yes, you're going to be sixth author on a study that you enrolled tons of patients and did tons of work on, but it's a really important question. So I think you want to engage with people who have the same sort of vision as you do to help form those networks. We, you know, brought other networks together, I guess, just through a shared vision of what we wanted, which was to improve the care for kids in emergency departments. You know, meeting each other at conferences, getting to know each other sort of on a more, I hate to say almost social basis, right? Like reaching out and just being friendly and interested, I think have done a lot. So to a new investigator, I would say, you know, if you do have a national network to get involved in, join in, try to identify who are the people that would be the good mentors there to help you get further on. And they usually know the people in other networks that then help you bring together, and make sure you have a common vision amongst the networks. And I think that's what's helped. And then, you know, when peds emerge, common things you can study, you know, in smaller studies, but the big questions like severe asthma, for example, you can only do that in a multi-center way, and some of the things you can only do in a global manner. And so really just keeping the view of what the answer is you're trying to get at, I think really helps engage other networks.
Great advice. Thanks, Amy.
Great. Thank you, Amy. Last question to Toby Otent.
Amazing presentation, Amy. This is maybe a bit of a cheeky question, but when all the bronchiolitis gurus are sitting around the table, has there been any conversation about, like, forget the steroids and the epi, let's just go for universal masking going forward? Because I think we've all been quite impressed by the fact that there's like no bronchiolitis this year. And if you think sort of $500 million per year, I mean, that's a lot of face masks that would buy if we were saving that money. So as a group, has the Bronchiolitis Network discussed sort of the what this year has been? Yeah.
Oh yeah, because I can tell you, I need 1,616 patients, and we've had 4 in Canada. 4 this year, and like 22 from Perth in Australia, because they had an out of season bronchiolitis season. So yeah, there's been lots of talks about it. You know, the issue though is it have to be like masking for everybody, right? Because you can have RSV more than once, your immunity wears, you can get it as weans, you can get it as an adult. You know, I think that it's very, it's not a feasible long-term strategy, but it does speak to the idea of, you know, not going places when you're sick, right? I mean, it really does speak to how you not only have we had no bronchiolitis, you know, we're trying to do studies with gastro right now. You can't get any patients with gastro, right? Yeah, there's way less infectious diseases, period.
Very true. It's as we start to talk about going back to normal, whatever that is, it will hopefully shape how we go back to normal, what that looks like in the post-pandemic era for us. Amy, thank you so much for a really great presentation. I think you really demonstrated such an amazing body of work, really helped us with management of these patients, and really demonstrated how, you know, being part of a really great series of networks really helps advance the science. So thank you so much, and wish everyone a good day. Please note that in the chat box, there's a few comments. There are the instructions for filling out the evaluation for today's session that will also give you credit for participation. Mary Pothos, I think it was Mary Pothos, commented that in response to Tom's note about spot checks versus continuous saturation monitoring, that is the practice on the ward. So that's very good. And of course, many positive kudos for the presentation. So thank you all. Have a great day.